Okay, let's just dive right into this. Welcome to The Explainer. Today we're tackling something absolutely crucial, and honestly, incredibly complex. How modern healthcare systems actually manage controlled substances. If you've ever sat back and wondered how these massive delivery entities, we're talking hospitals, clinics, rehab centers, somehow balance the desperate need to treat severe pain with the very real, profound risks of addiction, well, you are in the exact right place. Today, we're breaking down the specific qualitative metrics used to evaluate the safety of these practices, straight from the industry guidelines.
Now, to really get what we're talking about today, we've got to look at this crazy tension right at the heart of healthcare delivery. On one hand, on the left side here, you have the primary directive, right, providing care. And a lot of times that means prescribing highly regulated controlled substances just to manage severe pain effectively. But then look at the right side. You have the exact same institutions acting as the frontline safety net for addiction and overdose. It's wild when you think about it. They are literally the source of the prescription and the ultimate treatment center for the fallout. Managing this dual role requires incredibly tight policies because, let's face it, the financial and social costs of getting that balance wrong are just staggering.
So how on earth do we measure if a healthcare system is actually managing this tension responsibly? Well, we turn to the SASB standards, specifically the Sustainability Accounting Standard for Healthcare Delivery. These standards, which are now under the IFRS Foundation, are a total game changer. They give investors, administrators, and really all of us a concrete way to hold these massive systems accountable. By standardizing what gets reported, we can finally compare apples to apples when we're looking at how different hospitals mitigate the risks of these drugs.
So, the crucial point is how this actually gets measured. You'd probably think it's all about the hard numbers, right? Just counting the millions of pills going out the door. But honestly, the standard leans heavily into a qualitative metric. Specifically, metric HC-DY-268.A1. This requires entities to fully describe their policies and practices for managing prescription numbers. It is absolutely not enough to just say, hey, we prescribe less now. No way. The standard wants the how. What are the actual mechanisms, the written policies, and the daily on-the-ground practices that are keeping patients safe?
And this perfectly illustrates the comprehensive approach required here. It basically breaks down into what we can think of as the 5 pillars of practice. When a healthcare group reports these qualitative metrics, they have to hit these 5 key areas: utilizing monitoring programs, executing workforce training, providing substance abuse care, enforcing safe storage of disposal, and managing opioid antagonists. Think of these 5 pillars as the invisible infrastructure supporting the whole system. Let's walk through these one by one to see exactly what's required.
Pillar 1. Monitoring prescription output.
Right. So you simply can't manage what you aren't monitoring. The standard explicitly says a healthcare entity has to describe how they register for and actively use jurisdictional prescription drug monitoring programs. Because think about it, a hospital can't operate in a silo. Pharmacists and physicians have to be tapped into regional databases to see a patient's entire history across all providers. It's literally the first line of defense against overprescribing and doctor shopping. They have to prove exactly how this external data is baked into their daily internal workflow.
Moving on to pillars 2 and 3, training and patient treatment. So shifting from data systems to the human element, the standard gets incredibly specific about workforce training. We're not talking about some boring annual training video you click through while eating lunch. Entities have to detail the actual scope of their training, especially regarding the evidence-based treatment of pain. Plus, they have to identify the specific positions affected and calculate the exact percentage of the workforce that's actually covered by it. It takes a qualitative policy and turns it into a measurable program. You want to make absolutely sure everyone from the chief of surgery to the floor nurses knows the safest protocols.
Then we hit the third pillar, which circles right back to that dual role we talked about at the beginning. Institutions must describe their active programs to identify and care for patients who develop substance abuse disorders. Because let's face it, being a responsible prescriber means owning the inherent risks of the drugs you're giving out. An institution has to have documented, robust systems ready to catch the folks who fall into addiction. This metric basically proves if a hospital is taking full-cycle responsibility for their care.
Let's move to pillars 4 and 5, storage, disposal, and antagonists.
Okay, so this is where we get into the physical management of these powerful drugs. On the left, you've got safe storage and disposal. This is straight-up physical security, keeping drugs from being stolen, diverted, or leaking into the medical waste stream. But then on the right, you've got the exact opposite challenge: policies for opioid antagonists, the countermeasures. A truly comprehensive policy isn't just about locking the dangerous stuff in a vault. It's about proactively managing the distribution of the exact drugs used to reverse an overdose.
Now, what's really interesting about this slide is that the SASB standard actually spells this out, explicitly naming drugs like naloxone and naltrexone. By requiring entities to report on their policies for prescribing these antagonists, the standard elevates countermeasures from just an afterthought into a core pillar of institutional responsibility. It tells us that a well-run hospital doesn't just wait to react to an overdose in the ER. It has documented systemic programs to put these reversing agents directly into the hands of those who might need them, right alongside the original prescription.
Finally, limits and the bigger picture.
So we've looked at all these internal rules, but the standard actually leaves room for the macro realities of the healthcare landscape, asking a really provocative question. What factors limit an entity's ability to manage these prescriptions? And this is the thought I want to leave you with today. Even if a hospital has pristine training, perfect data monitoring, and Loctite storage, they are still operating in a complex real world. They face external constraints, demographic shifts, regional disease outbreaks, or changing local laws that can completely force their hand. Understanding these external limits is just as critical as knowing their internal policies. It's a massive dynamic puzzle. So the next time you walk into a hospital, ask yourself, what systemic, external factors are actually limiting their control today? Thanks for joining me for this explainer. We'll see you next time.